our moderator here on board with us, and I'd like to introduce you to her. She is Dr. Nino Karashvili. She's a healthcare expert with working knowledge of 40 different countries across the former Soviet Union, Africa, Southeast Asia, and the Middle East. She specializes in global health security, health system strengthening and preparedness, disease surveillance, biosafety and biosecurity, program metrics and evaluation. Currently, she works at Jacobs, where she serves as the Global Health Solutions Director. So thank you, Dr. Karashvili, for joining us today, and I will kick it over to you. Thanks.
Thank you so much, and thank you for the wonderful introduction. Good afternoon, everyone. I'm very pleased to be here and have a pleasure and honor to be a moderator for the first Health Engineering Task Force webinar. As Elisa mentioned, we have a fantastic group for you who will be presenting and sharing their lessons learned and experiences from their COVID-19 deployment. As mentioned, we have 5 panelists, and I would like to introduce the first speaker, Commander Leo Gumapas. He serves at the National Institute of Health and oversees the development of the Environmental Compliance Program and the Industrial Water Treatment Programs for the NIH Bethesda Campus Central Utility Plant. In 2018, he co-developed a Surgeon General Chartered Advisory Group titled Prevention Through Active Community Engagement, which is focused on educational outreach in local communities. He recently received 2020 National Society Professional of Engineers NIH Engineer of the Year Award. Commander Gumapas, floor is yours.
Thank you, Nino, for the introduction. So while my slide is pulling up, I'm going to give a talk about 2 deployments I did, one at Travis Air Force Base and the other one at Commission Corps headquarters. So I have no disclosures to report, but this is a title of my presentation, and Nino, you can move on to the next slide, please. So regarding my deployment at Travis Air Force Base, a little background. On March 9th, 2020, the Princess Cruise Line pulled into the port of Oakland, and there was more than 3,000 passengers that had been exposed to the novel coronavirus. And these passengers were taken to different federal military installations for medical screening, COVID-19 testing, and a 14-day quarantine. And so that's a pic of the cruise ship as it's pulling into the port of Oakland. Next slide, please. So when we arrived, could you go back one? Backwards, Nino. Yep. So Travis Air Force Base was one of the quarantine stations that I was stationed at, and I manned the night shift along with my other counterparts, as you can see in the picture. And we received almost 1,000 passengers, and the other remaining passengers were routed to 10 other sites across the U.S. based on their COVID-19 status. So we set up this Google Doc site to track the multiple issues from these 1,000 passengers and try to resolve multiple issues for their stays. And one of those recurring issues that we always kept on seeing after we resolved a lot of their issues was missing luggage. And what we assessed was about 3.5% of these passengers did lose their luggage while being routed to federal military sites. So at the end of the day of our shift from I worked from 7 p.m. to 7 a.m. the next day. So from 7 p.m. to 11 p.m., we were busy taking care of issues until they went to bed. So from 11 p.m. 7 a.m., you can move on to the next slide. We sorted out luggage. So you can see it on the lower right, but there was over 400 pieces. And so me and Captain Mike Smith, we alphabetized them, and we knew rain was coming to Travis Air Force Base, and we didn't want that luggage to get rained on. So after we alphabetized it, we called 104 different people and found out where this luggage needed to go over a 3-day span. We coordinated the logistics, got 2 16-foot box trucks to move that luggage. Me and Captain Smith drove 188 those bags to Miramar Air Corps Station in San Diego from Travis, which is basically an 8-hour drive. And we did it round trip, dropped out the luggage and gave it to the passengers that were stationed there. And then the other 237 bags needed to be distributed to 10 different locations that we worked out. And there was other engineers that helped support distributing that luggage out. So you can move on to the next slide. The other thing that I did was at headquarters. So as we all know, COVID-19 did create a huge demand on our agencies for responding to COVID-19. And in addition, us as public health service officers also have a duty to respond to our nation's needs. So because of that, our IT infrastructure within headquarters couldn't track the additional attribute regarding agency needs. So there was a lot of emails that were going around with how all these statuses were being tracked. So one of my co-panelists, along with a team of other public health service officers, we developed this custom solution to take all the emails and all the Excel sheets and even the reports from our actual enterprise system to develop a custom solution to track all the skill sets, all the information, availability, mission critical, and route it into an access database that pushed out the data into a SharePoint so that all the stakeholders could be informed. The other thing is that Commission Corps is stationed across 20 other agencies, and some of those people couldn't get access to the SharePoint. So Commander Coburn, the other co-panelists, developed this cool idea to develop these same information through emails by pushing a single button. So he developed a lot of that VBA script. And so we were able to export all that data so that all our stakeholders could understand the actual status of these officers that they deployed out. And then we also developed a custom solution to automate report outs to leadership so they can understand what is the availability of the Corps to respond to missions. You can move on to the next slide. As you can see, I know it's kind of small, but this is kind of like the business logic of the brain of how that access database was built. But in terms of the specs, it does execute 41 business rules. So just kind of like based on the dates of what certain things, it will update those statuses. It can process thousands of records from our enterprise system to recreate all the attributes so that the latest decision on an officer can be determined. And as I mentioned before, it does develop these automated reports to apprise leadership. So all of this doesn't require any manual like clicking and dragging and copying things. It's just single button, and it does all the extraction, transforming, and loading that data into various reports to meet all the client's needs. And that concludes the brief.
Thank you very much. I appreciate the detailed report. And we will move to the next speaker right now. Let me introduce Commander Patrick Clutberger-Cruz. Since joining the USPHS, he served as an investigator with the US FDA Northern Virginia office. He later supported the medical products program of FDA's San Juan district, and then selected as a senior regulatory operations officer with the Division of Foreign Field Investigations dedicated drug cadre. To date, Commander Clutberger has conducted operations in over 30 different countries, to include investigations of both small and large molecule manufacturers, all varieties of profile classes, and the facilities associated with the first US FDA-approved continuous manufacturing drug application. Since June 2020, he has served as a drug compliance officer, developing risk-based enforcement strategies to address immediate patient health risks and reduce and prevent patient harm. Commander Clutberger, the floor is yours.
Thank you, ma'am. Good afternoon, everyone, and I apologize, I'm having some connectivity issues, so please bear with me. If you can advance to the next slide, the first slide. If you all can remember, back in March, a number of hotspots started to develop across the nation for COVID-positive patients and suspect patients. At that time, HHS received a mission assignment from the White House Task Force, essentially to stand up in various strategic locations in order to provide a track and trace capability for COVID-positive patients. Each of these sites, they were intended to be community-based testing sites with federal oversight of actual tangible state operations, meaning that our Deputy Surgeon General would serve as the prescribing provider for all tests that were being run. Federal contracts would be in place for shipment and logistics, and the actual clinical testing, and call centers were set up for patient notifications. But the actual tactical operations would be conducted by governor's offices in each of the respective states. We as Corps officers, we were essentially deployed to train, advise, and assist these local National Guard and other units, but also to ensure the viability and the chain of custody of the physical samples that were being collected, and the patient information that was being gathered and associated with those samples. Next slide, please. Basically, we were deployed and given a lifeline in the form of a FEMA supply chain for stocks of materials and a very, very basic early concept of operations. The concept of operations was developed as either a single or a dual lane drive-through testing operation, and developed with the intent to minimize personnel exposure of those performing the testing and also minimize the PPE burn rate while we could provide a throughput of over 250 patients per site per day. We deployed, myself in particular, and another engineer, Commander Shane Decker. We deployed to New Orleans, 3 different sites spread across the city, and we stood up the first government-operated CBTS site on the 20th of March. Next slide, please. You should have a picture of a very basic diagram of a CBTS tactical plan. So this is essentially the tactic that was used for basic sample collections, or the prescribed tactic for sample collection, but it doesn't show the full operation. Essentially, you would have a patient come in, drive through, be screened for certain testing criteria, proceed on to a follow-on station where they would provide their patient information, any insurance information, or any other additional information that was to be forwarded onto the laboratory and eventually onto a call center. They would proceed to another station where the actual swabbing would be performed, usually in the form of some healthcare professional, whether it be a basic medic, a 6-day whiskey, or somewhere more mid-level or advanced provider. And then they would progress onto receiving contact information for the call center, where they would receive results and receive notification of their status. What this doesn't show is, all the back room work that went on in order to maintain custody of the physical samples and the patient information, the packaging and shipment and decontamination of the samples and shipment towards laboratories, and the relay of the patient information to a laboratory, and then further on into the call centers for notification. This CONOPS, it evolved over time. So like I said, initially we were deployed as a single or dual lane operation for 250 plus samples that quickly expanded up to 500 plus samples per day per site. And the rate limiting factor in the entire operation was typically the contract that we had established with our private laboratories. So on the back end, those individuals doing the clinical testing in laboratory were severely restrained. This also expanded in the terms of criteria. So we initially started with testing of first responders and healthcare professionals only, which then progressed into general population and the elderly over the course of several weeks. If we could. The concept of operations itself also expanded. So as we were performing swabbing and testing initially, where we would have physical hands-on patients, that evolved in an effort to maintain good stewardship of our stock of PPE. So as to reduce our footprint and our burn rate because of the situation going on in other areas of the country, we implemented rapid self-testing. So individuals will be able to come in, pick up their own test kit, perform their own swab, place the sample back on a table, have it be decontaminated, and we didn't have to, in most cases, we didn't have to have any direct patient contact, and by proxy, we would reduce, our burn rate of PPE or our actual introduction. Next slide, please. So after completing the first round of CBTS operations in New Orleans, I was sent home for a couple of weeks of quarantine and then called upon to join Strike Team 6. We were deployed out to the Navajo Nation to assist in their COVID-19 response. Due to the surge in their number of cases, given their population density out there, there was grave concern, especially given their healthcare capacity to begin with. So we were sent there essentially to set up a 40-bed ACS, ACS being an alternate care site specifically for COVID patients. That quickly shifted once we were on ground to augmentation of the existing hospital there in the in Shiprock, the Northern Navajo Medical Center. So we maintained that 40-bed ACS capability, but we shifted to augmentation of clinical operations in the hospital itself with pivot plans in place and shifting back to the ACS for any type of patient overflow. Next slide, please. On your screen, you should have a picture of the interior of the ACS. At this point, it was still empty. So from May until July, we had a deployment of a 36 officer team reporting directly to ASPR's incident management team in that area. Approximately 75% of the team had some type of clinical proficiency, which was put to use in the hospital. And again, like I said, with pivot plans in place and with the capacity to pull back into the ACS for any patient overflow. At ACS, it was really used as an adaptation of our existing federal medical station, tailored specifically for COVID patient isolation and COVID, low acuity COVID patient care. Next slide, please. Here you should see a picture of myself and the other fellow engineer that was deployed with me, Commander Ed Zekman. He was deployed as a logistics deputy. I myself was a planning section chief. And like I said, the ACS was to be utilized for low acuity patients and isolation of any persons under investigation. So people that were suspect of being COVID based on symptoms, but still awaiting test results. And the two of us as engineers in a 36-member team of, qualified clinical professionals, we had limited interaction with patients firsthand, but then providing support in the form of utilities or facilities type of work and all of the back house type of coordination that was required, essentially making the gears turn. And that concludes my brief. Thank you.
Thank you so much, Commander Klotbacher. That was very exciting presentation, and I'm sure the experience will be very interesting for others as well. I want to share the next, I want to do the introduction for the next speaker, Commander James Coburn, who is the Senior Advisor for Emerging Technologies in the US FDA Chief Scientist's Office of Counterterrorism and Emerging Threats. He currently provides leadership and coordination to a cross-cutting innovation center for advanced manufacturing and consultation to FDA's 3D printing core research facility. As a side note and fun fact, as the lead for the 3D printing lab, Commander Coburn once made a bobblehead of the FDA commissioner as a gift. So Commander Coburn, the floor is yours.
Thank you very much. And thanks for the opportunity to share my experience here. So I was part of the Strike Team 1, which went to the Javits Center in New York City. And I'll be telling you a little bit about my experience there. Next slide, please. This was an alternate care station, just like the commander described his as well. This one was a little bit different because it had over 40 different agencies in it. The number of command structures and personnel and different activities that were going on is truly staggering. We were primarily working with the 531st Hospital Center, the 9th Hospital Center, the 44th Hospital Brigade, and the later EMF, or the Emergency Medical Expeditionary Medical Force, Bethesda, Navy. So that was 3 Army and Navy group. But it also included Coast Guard, National Guard. The USS Comfort came in for a while, docked outside. So it was a just amazing flux of people and a mission. We lasted from March 31st to May 2nd when they really needed a lot of extra help before the city was able to stand up its own alternate care sites. And as you see, we had not only a 500-bed regular kind of low acuity facility, we also had a 48-bed ICU provided by the Army hospital centers. Next slide, please. Just to give an idea of the scale of this, I don't know if you can see in the picture on the top left, you see the black circle or oval, that's this room that you're looking at. And if you look at the streets, you can see streets there. So this building is 4 city blocks wide, and this room is 1 city block in every direction. So it is a very massive facility. And my job there as an engineer was to support the clinical staff, as other people have said as well. So we had amazingly complex logistical activities, which luckily the Army was taking care of, but the data management was also an issue. They had paper records for all patients, but the city would like also for them to be trackable and traceable after they came in. and after they left, because they're still going to go back into the city's electronic medical records. And so I worked with the S6, the IT group from the 531st to put together some tracking and tracing. Next slide, please. Oh, sorry. I forgot to say. So this was going to be showing you scale. So that other oval there, you can see that you can see pallet containers and tables and things like that. So that's how big this room is. It takes like 5 minutes to walk across. Next, please. Most of my work ended up with the patient administration group, and we were, as you might expect, from the start of when somebody arrived, next click, to when somebody left the building. And you can see here the facility, obviously a full COVID facility. We had 12-hour shifts, masks on all the time. Most difficult for the nursing and the physician staff, more so than the pad staff because of the workload, was they could only take snack and bathroom breaks on 1 break per 12-hour shift. It was pretty grueling shift. Next, please. So how did we keep everybody straight? We also did a locally online document that we could track. We essentially made our own bed tracker if anybody's worked in a hospital before. And it was automatically updating which beds were taken to the nearest supervisor, because as we took in beds, you can see this line. This is the line outside of the Javits Center where the ambulances came in. When they came in, they didn't fool around. We were taking in between 10 and 20 people per hour at the high times, and then 0 at the low times. So it was just either a flood or nothing at all. And these logistical or administrative activities that we were able to put together really helped the nursing staff and the physician staff cope with putting people and spreading out their workload so that none of the nursing staff was overwhelmed. Next slide. The other activity that was critical was tracking all of these patients, because not only did the city want their medical reports back, it seemed like every command group also wanted a report of the status, either hourly or half hourly. And in the first 2 days, I believe we had about a dozen different people from the different command structures making reports every hour. So that was essentially 24 to 48 person hours wasted per day if you added them all up on reporting. So we created this composite automatic tracking system which linked directly to the bed tracker, and you can see here, if you look on that one graph where the pointer is, some days we just crushed it and got a huge number of patients in. The blue is number of in, green is number of out, and then you can see the cumulative track as it goes. But this document essentially stopped us from having to do any of that reporting work, because we were able to link it to the command staff that were remote, and internally people could put this up on the big board, and it really increased our efficiency. So it was one of those data management engineering solutions that facilitated all the clinical activities. Next slide, please. So it was an amazing time. We made 1,000 different contacts with patients in and out, and we were able to close up the facility with a very low rate of COVID as well among the responders, and it was great to be able to experience that and tell you about it. Thank you.
Commander Coburn, wonderful presentation and fascinating experience. Thanks for sharing that with us. Let's move to the next presenter. Let me introduce Lieutenant Commander Praveen KC. He is assigned to the Environmental Protection Agency and manages the National Energy Independence and Security Act program, keeping EPA labs and facilities countrywide in compliance with federal requirements. He also serves as the lead mechanical engineer for lab renovation project, as well as in-house subject matter advisor for laboratory ventilation design and human food testing certification projects. He joined SAME in 2013. He was awarded SAME Plague plaque, sorry, my apologies, for 2017 Hurricane Relief Support and SAME Green Medal Award in 2015. Please, floor is yours.
Thank you for my kind introduction. Good afternoon and good morning, everyone, wherever you are in the country. This is Lieutenant Commander Praveen Casey. Topic of my today's presentation is USPHS engineer's story in COVID-19 response. I'd like to thank M.SAME for allowing me to share my experience with you all. My deployment was during the mitigation phase of our nation's COVID-19 response. This summer, I was deployed. I think you went too fast on the slide. Could you go back, please?
Sorry, the slides seem to be changing themselves for some reason, so bear with me.
Okay. One more? Okay, perfect. Let's hold it there. Thank you very much. Apologize for technical issues. It does happen now and then. So, moving on, my deployment was during the mitigation phase of our nation's COVID-19 response. This summer, I was deployed as a health facilities engineer as a part of 16-member augmentation team to Phoenix Indian Medical Center in Phoenix, Arizona. When we arrived here, PIMC's emergency department and ICUs were operating at full capacity, and the staff of PIMC were overwhelmed. At that point, Arizona was one of the highest. Now, Arizona had one of the highest case of COVID-19, and the rate of infection was among the highest in the country. Next slide, please. Thank you. I was deployed to support engineering department of Phoenix Indian Medical Center. There, I was able to inspect airborne infection isolation room, HVAC systems, and did some troubleshooting over there. Inspected the dental clinic HVAC system, and did some retrofitting. I also did the airflow assessment for emergency department because the case among the healthcare provider was rising too over there, and there was a concern if there was a cross-contamination. We just wanted to look into what's going on from engineering standpoint. Also did an airflow assessment of operating room, and also provided some support to the housekeeping department. Next slide, please. My first task was to inspect all airborne infection isolation room at PIMC. At that point, they had 9 dedicated airborne infection isolation room. For that, I created a 6-page checklist and inspected 9 AIIR, airborne infection isolation room, compiled a report on the current status, and also identified the tasks or the items they need to look into if they want to renovate this space, because this space was last renovated in 2008, around like 2010. And as you all know, when you do a major renovation, you have to comply with the current code. So we also identified what are those. The understanding of, could you stay back, please? Yep. Thank you. Sorry, I apologize. Understanding of CDC guideline and life safety code NFPA 101 and healthcare facility code NFPA 99 is very important when you are inspecting isolation rooms. The knowledge of ASHRAE 170, especially for airborne infection isolation room, is must when you are evaluating the infection isolation rooms. Next slide, please. As you all know, a properly designed HVAC system is key to a good indoor quality, air quality, infection control, and cross-contamination. During my time over there, I was able to check each and every component of PIMC's HVAC system, identified a few major issues, but PIMC were quick to jump into the action and took care of it. All the red circle that you see in this pictures on the right, we identified some maintenance issue or possible, the word is possible, we were still evaluating at the time, possible code compliance and health and safety issues. PIMC is currently working on fixing it. I believe by this time they may have already taken care of it. This thing I have highlighted was from July. Because of COVID, a lot of facilities has done temporary modification to their HVAC system. we want to make sure that those modifications are documented and are in compliance with CDC guideline. For example, maintaining the distance of exhaust from the operable windows or outside air supply intake, because you definitely do not want to recirculate the contaminated air back to the clean space. So like what kind of issue were major was like we found that some of the dampers were stuck or had a bad sensor. That's why it was not those HVAC system or air handling unit were unable to bring proper amount of outside air required by code. So those are the minor stuff, because when you do not look into this stuff for a long time, dust and other natural cause can make damper not function as it was designed. Next slide, please. So there was a concern within the dental staff that with the current ventilation system, they may be vulnerable while treating the asymptomatic COVID-19 patient. Facility manager requested me to look into it and asked me if we can do some sort of retrofit, and asked me to submit a proposal if we can take care of it. I was able to look into, we checked all attic space, crawl space, everywhere, how we can make those modifications. I submitted a proposal that has a schematic diagram and cost estimate based on CDC guideline for and recommendation for dental setting. CDC does have a separate recommendation on engineering control for dental setting, which is a little bit different than for regular healthcare facilities. Photo is of the schematic design and retrofit that is now complete. As you can see, in a desperate time, you do a desperate design. In any regular time, I would not consider this as a good example of engineering drawing, but this was a hand sketch schematic that we used, and actually the system was installed and is operational. A HEPA filter fan are lifesaver in these kind of scenario. A direction of airflow is important. Those sound simple. Supply high from the provider side to return low toward the patient side is important to the dental setting. When you install a HEPA filter system, make sure you have your fan system can handle the pressure drop. If not, you may need an inline booster fan. We decided to go outside after like a treatment space because there were no space available in attic or in crawl space, and by going outside, it did not disrupt the operation of the dental clinic. Next slide, please. Upon request from our safety officer, I conducted an airflow assessment of emergency department, identified few areas of cross-contamination. PIMC is currently working to fix it. Most probably they have already fixed it by now. My assessment was from the July 2020. I also identified the opportunity to save energy, though it was not my intent of this assessment, but also find the possibility to save energy. My calculation showed that this space was not commissioned properly, and you can see in my design, some places you have almost 600% higher than the design air supply rate or air change rate. So to make a room negative, people always think that increasing a return from a room is is where people generally spend their time. Very few people think about choking the supply of a room and adding more air in a hallway. You know, this way people can change a room from positive to negative without overloading an HVAC system. If you do not like change the supply and keep on increasing the exhaust in each room, because the general perception is people want to make this room negative, you just have to jack up the exhaust. From the negative or positive standpoint, the system doesn't see where the air is coming. So it is good to look into, like, just increase the air supply in a hallway by not changing the air return in the room. That way you can keep the air change rate required for that space and keep those room negative. What we have noticed is not every, like in a hospital, there are only 5 or 10, depending on the size of the hospital, 5 or 10 infection control rooms, but during this unprecedented time, there were like hundreds of patients in any given day. How do you adjust them? You know, the general perception is you put those patients in a negative room. To do that, you just have to change the direction of the airflow. And if you keep the airflow from clean to dirty, you will contain that dirty air in that confined space. Next slide, please. Upon request from our OR director of PIMC, I also conducted an airflow assessment of OR, verified that it complies with the COVID-19 policy. Though they created a policy, they didn't have enough time to check or verify that it still complies with their COVID-19 policy. Back to thank you. I also created a record drawing for documentation proposed, saying that this is how the airflow is in this OR. I also confirm that all modifications are in compliance with CDC guidelines, because things were very dynamic and people were making a lot of modification. Sometimes there is always a possibility that you may overlook on what the guidelines is, because the need is there to make those changes quick. But the good thing was PIMC were, the modifications made by PIMC were still following the CDC guideline. Next slide, please. So there is always a tussle in any healthcare facility that the doctors and nurses want the room to be cleaned quicker, but the housekeeping staff are always concerned that room is still not ready for us to go inside and clean it. So there is always a tussle between the housekeeping versus the healthcare team. So seeing that, I proposed and created a contaminant flush diagram based on CDC guideline and the air change per hour in each room. You see this room, and what we suggested was you keep this diagram in each suite. If you do that, not all healthcare, the housekeeping crew understand English, or they are different ethnicity who are not like me. I'm not good with English. I'm rusty. So there's always the likelihood of that, but looking at this diagram, they can easily say that, hey, this room, I have to wait an hour. So then I can feel safe. This diagram provided the amount of time housekeeping staff has to wait before they can enter to clean a COVID patient treatment room after patient is discharged or relocated. This diagram also helped train the new employee, because there the turnaround in the housekeeping staff was also high, because people are getting infected or people are stressed out with the work. So in case, like we now see that the cases keep on spiking on rural community, engineering controls in rural community will be tested under, the engineering controls in the clinic in the rural community where we do not have the best O&M staff will be tested when the case keep on surging. So I hope and pray that the modification they make to their system is capable to help them avoid cross-contamination and keep their patients safe, as well as their healthcare providers safe. Next slide. Actually, that is all I have pending. Any question? This concludes my presentation. We'll be around if you guys have any questions. Thank you.
Thank you so much for sharing this very interesting presentation. We have, last but not least, Lieutenant Kevin Remley, who is currently stationed in Fort Hall, Idaho, as a senior environmental engineer with the Indian Health Service, where he improves the sanitation facilities of underserved and vulnerable populations. Lieutenant Remley joined SAME in 2018 and currently serves as the Service Liaison Officer for USPHS. He's a member of SAME Leadership Development Program Class of 2021 and part of the Health Engineering Task Force. Lieutenant Remley's awards include the USPHS Individual Achievement Medal, as well as the 2018 IHS Portland Area Directors Recognition of Excellence Award, and the 2019 IHS SFC Portland Area Senior Engineer of the Year Award. Please, floor is yours.
Thank you very much. So my deployment to the Navajo Nation is a little unique. My deployment was not actually with the Public Health Service, but it was actually a agency deployment with the Indian Health Service. A little background on that. When the COVID-19 pandemic started, it was discovered, since we have a lot of PHS officers and the Indian Health Service, of course, involved in Native American communities, it was noted that if you were to take the Navajo Nation as its own state within the country, it was one of the hardest hit areas in the nation. And so the Indian Health Service and the Centers for Disease Control combined efforts to figure out what was going on the Navajo Nation. And they found that a lack of access to clean drinking water was a leading driver for the spread of COVID-19, because a lot of homes on the Navajo Nation did not have easy access to clean water for proper sanitation within their homes. And so the Indian Health Service was able to secure CARES Act funding to help address this issue and provide better access to clean drinking water as best as possible during the course of the pandemic. The mission started to design and construct, I have listed on here, we ended up with 59, but in the beginning, back in the May-June time period, it was originally going to be for about 35. But as more investigation happened on the Navajo Nation, it was discovered that additional areas on the Navajo Nation wanted to have better access, and so they decided to participate in this program. But overall, it was to bring better access to over 3,700 homes. And then we also had the mission to provide the training to the chapter officials. I'll explain what a chapter is on the next slide, on how to maintain what we were installing as these transitional watering points. And then ultimately, the mission was expanded even further to provide 5-gallon water storage containers to every individual that would have access to these transitional watering points. And in addition to that, disinfection tablets to be given to whenever they would fill up their 5-gallon storage tanks, because during the investigation phase, it was discovered, based on records on the medical facilities on the Navajo Nation, that there was a high rate of GI issues. And this was tied to, because of the lack of access to water, individuals that have to travel 20 miles or so to get to what's called a permanent watering point, fill up their 100, 200-gallon water tanks, take that back to their homes, and then use that water over the course of months or a month or so. And because that water would sit stagnant, the chlorine residual was not enough, and so naturally, without the chlorine in there, you get the bugs in the water that would then cause GI issues. Next slide, please. So on the Navajo Nation, if you were to take it kind of like its own nation, they are separated into chapters, and that's what you see here. And on this diagram shows they have existing permanent watering points. So these are locations on the nation that people could drive to or travel to be able to get water to then take back to their homes. Water distribution on the Navajo Nation is very difficult because of the economic infeasibility of just drilling a bunch of wells. The wells to reach water are very deep, require very expensive pumps, and the communities on the Navajo Nation are spread out all over the place, very remote areas. And so then to be able to get a distribution system that can get the water to every individual home at this point is economically infeasible. And so our mission was to put in these transitional watering points, which are the blue markers on this map. Next slide. So transitional watering points were pretty simple in design. They were designed as yard hydrants that we tapped into existing water mains that were already within the area. And so these water hydrants were to be taken over by the chapters. So like the individual states, the chapters, it was done, these were designed near the chapter houses, which you can kind of think is kind of the capital of a state, the Capitol building, the chapter house. It's where the leadership of the chapter was located. And so they would be responsible for the ownership of their watering points. And we coordinated with the chapter officials on where they wanted the watering point to be installed, and then how we had two different options for them. They could either have a fenced watering point that was completely fenced in and secured, or if the chapter house area was already secured, they could go with an option that just had bollards around it to protect it from potential vehicular damage or anything like that. And so pictured here, typically we just do a lot of excavation to install the water lines, and then of course tap into the water mains, and each one was provided with a water meter, and if needed, a pressure reducing valve to deal with any pressure issues. And the meters were installed because the chapters were going to take ownership of these watering points. The mission, the funding for the mission, was to provide funding for water use during either 2 years or until the pandemic ends, whichever comes sooner. So during that time period, the Indian Health Service with the CARES Act was going to cover all the costs of the water. But after that was done, the chapter houses could continue to use these watering points, but they would have to pay for it themselves to the Navajo Utility Authority that owns the water distribution systems. Next slide. So here, here's a photo of, on the left is one of the fenced, and on the right is a photo of what the bollard yard hydrant looked like. Next slide, please. And then in the middle here is an example of a community outreach that would happen. So once design was complete, our officers were then responsible for training the chapter officials on the use and management of the watering point. So these were secured, meaning the individual Navajo members, this was not open to the public. They would have to come to the chapter house, talk to the chapter official, have the chapter official unlock it, then let them use it, and then provide them the disinfection tablet, and then lock it back up, secure it. So this was not available for anybody to just drive up and use. It was for specific use of individual homeowners. Next slide. So in the end, we were able to design, construct 59 transitional watering points. So far, over 66,000 disinfection tablets have been provided. We also provided PPE for each of the individual watering stations. So we have a lot of hand sanitizer, gallons of hand sanitizer provided. And in the end, I mentioned the 3,700 homes, but the real impact of this mission is that over 16,000 people on the Navajo Nation now have better, easier access, where they maybe have to travel a mile or two to get clean water with their individual 5-gallon container, instead of having to have a vehicle with a much larger water tank. And this mission is just about finished up. We have a little bit more of community outreach to complete, as well as distributing those individual 5-gallon containers and the disinfection tablets. But it has been one of the most amazing experiences in my life to be part of this, and proud to say that we in the United States Public Health Service, we are out there serving on the front lines right now during this entire time of the COVID-19 pandemic across the country and in many different capacities. And thank you all for joining us today. And this ends my report.
Lieutenant Rumley, thank you so much for sharing your experience, and your last sentiment that you just said, that you're very proud. I think it's shared with by many people who are posting in the chat. So this concludes our presentations, but we have around 9 to 10 minutes to answer questions. Please use the chat function to type up your questions, or you can directly ask a question to the presenter. We have one question that I would like to pose to Commander Barker or Commander Coburn. At the temporary facility space, Was there a design manual that was followed? Any challenges with support spaces, salt collection, clean restrooms, nurse stations, etc.? Please, if you don't mind answering.
Sure, I can answer a little bit of that. We were working with the Army Corps of Engineers on the design and layout of the space, as well as the Javits Center facility crew. I think we were in kind of the ideal space for this, because the Javits Center is a conference center made for thousands and thousands of people to come in, which really helped a lot. The facility has several different levels, and so we were able to put clean kind of transfer points at different elevator shafts, so that either supplies or food could be transferred in to the dirty space or the COVID space without a lot of additional measures. And we were also able to bring in portable bathrooms for the COVID patients that were separated from the normal facility bathrooms that were used there. I guess the last part would be that we were using a plan, but because at that point, I mean, you have to remember this was March, so we didn't really know a lot about COVID and how it was transmitted, how people were getting it, and how much PPE we had to use. So things changed a lot with workflow, where people could go, where they couldn't go, where they needed PPE, and that developed in concert with Corps of Engineers, the Army Command, and PHS Command as well.
Thank you. I believe Commander Bucker had some technical issues. I don't know if he's dialed back to add a comment. Maybe not. So next question will be for Lieutenant Commander Casey. Would you please discuss air filtration? So air filtration with respect to COVID. Can you guys hear me? Yes, we can hear you. Okay. So with respect to air circulation and filtration, there are a couple of requirements that CDC guide. It depends on where first, okay? Are you talking about dental setting? Are you talking as a HVAC system as a whole? Or are you talking particular room like an OR? OR generally are kept in positive pressure in regular time, but if you are operating on COVID patient and you want to keep that room negative, also make sure that you are not recirculating. OR are generally, if it's in the middle of the core of the hospital, you may have to end up adding some HEPA filter if that is connected back to the return. If not, if possible, my recommendation would be, if possible, avoid filtration and rely on exhaust, if possible. I would say 90% of the time that is not possible. The code requirement in this is you rely on HEPA filter. So you install HEPA filter on the return line even before that air is mixed to any other return air. That is a requirement of ASHRAE 170. Thank you. Question. Thank you. There's a second question that probably also comes to you, Lieutenant Commander Casey. And the person is asking, I'm looking for resources for conducting an audit for our church building before we reopen the facility. If anyone has any recommendations regarding indoor air quality and filtration needs, would be good. I would say, because this will be a long chat. So I would recommend that Mr. Bond, please contact me via my email that will be distributed after this presentation, and I will route you to the proper guideline and code requirements and a couple of things that you can do yourself to avoid any cross-contamination or redirect the airflow to avoid cross-contamination, which is a major thing with the pandemic or with COVID. And I'm happy to help. Commander Casey, there's another question for you. Would you recommend 100% outside air for supply? My question to Mr. Mueller would be, which space he's talking about?
Question is really vague. It depends on room. I would always, if you can handle the cost of bringing outside air by not conditioning, it is the best way to do it. But you can handle that from the cost standpoint. You know, if you are general is 20 to 30%, if it's a regular patient care environment, you bring like 20 to 30% outside air. But in certain areas, there is always a one-pass system. So it depends on which space he's talking about. And if he wants to talk in more, we could talk with him personally after this. But it depends on the space. So if you can handle the cost of running the air handling unit and your HVAC system is capable enough to condition that air for 100% outside supply, that is the best way to do it.
Fantastic. Thank you so much. We have just a couple more minutes before I hand it over back to Lisa. And I wanted to ask one quick question to Commander Gumapas and Lieutenant Remley. Would you mind sharing one lesson learned from your experiences? This is just a one last closing remarks, and then we'll close the session.
Yeah, sure. I mean, one thing that we did with everything was just the straight data sharing and having a common operating picture so that we could leverage everyone's expertise. So that's what we did at Travis with the luggage. I mean, we didn't build anything as robust as what we had for headquarters, but generally just having that Google Doc to work with the 10 other sites so we can locate the luggages of individuals, and then using that to involve all our stakeholders so we can understand the capabilities of the availability of officers to respond. So having a common operating picture and everyone having the same set of rules of how to operate, it can definitely exemplify something to be able to accomplish something bigger as a collective than what we can do individually.
Fantastic, thank you. And Lieutenant Remley?
Yes, for me, something I didn't mention during my presentation, but the entire mission for the Navajo Water Access was separated into, I think they're going into Team 7 in January to finish things up. I was part of Team 3 that oversaw the construction of the watering points. And I think one of the lessons learned there was to be patient with yourself when you are in these mission critical situations where deadlines are tight, things are moving very fast. Keep your head cool, but also making sure you double check what you're doing makes engineering sense. We did run into a couple hiccups on the design of these transitional watering points that I don't fault the previous teams because probably would have done the same thing that they did. But we were able to remedy it in the end, so it wasn't a big deal. But just being able to take that little bit of extra time, even though you're pressured, just to double check your work and ensure that engineering-wise, things should work as intended.
So there's one last question for you. Were watering points installed at other Native American nations? Just a quick one to squeeze in.
Not that I'm aware of. From my knowledge, this is the first major mission that, at least within Indian Health Service, that we have conducted. So but it could certainly be a template for providing access to other reservations that have very remote populations without the means to get water to every individual.
Thank you. Lieutenant Commander Casey, you have a question or remarks?
Not a question, but kind of like a remarks. Just want to share that PHS engineer officer are not in the public most of the time. This was unfortunate event that brought us out. What we like to share is like, we can be your problem solver. We can be your electrical, we can be your mechanical, you can be your data analyst. You name it, we can be anything you want us to be if you need us. Give us your problem and we'll find you a solution.
Thank you. Thank you, everyone. Thanks for a great attendance, great questions. I'll hand it over back to Lieutenant Colonel Hammer, please.
Very awesome. Well, thank you all. Thanks for dialing in. We really appreciate it. Please stay tuned for further Health Engineering Task Force meetings and initiatives. We meet right here the third Thursday of every month, 1200 Eastern Time. Our next meeting is the 21st of January, 2021. So thanks again. We'll be sure to have the speakers' contact information for you. You'll see the slides at our website. I did include the link at the chat function. I've seen a lot of great comments and praises to the awesome speakers. And so we'll make sure they see that too. All right, well, thank you again. Please have an enjoyable holiday season and a really prosperous, happy New Year. Take care, all.
Happy New Year.